Hello, everyone, and welcome to Frankly Speaking About Cancer Immunotherapy. I'm Kelly Kraft with Gilda's Club Quad Cities, and before we start, I just want to give a little bit of background about what Gilda's Club Quad Cities does. We are a cancer support community that provides 100% free psychosocial support to anyone impacted by cancer. So that's a person with an active diagnosis, that's survivors, friends and family, caregivers, all the loved ones, kids and teens, anyone impacted. Everything we do is 100% free, and we have programs like support groups, and we have educational workshops like this one, healthy lifestyle activities, so that's like yoga, chair yoga, meditation, things like that. We're also a hub for resources and referrals, and we have kids and teens programs as well. So I'm going to get started here, and I'm lucky to be here with Dr. Bacalanga for immunotherapy tonight. And this is just the medical review. We have our workshops regularly reviewed by medical professionals. And just so you know, this workshop was made for us by our headquarters, and just a few other details there if you're interested in looking at them. And this is our presenter disclosure. And then from here until a little while later, I'm going to give the doctor the little clicker here. And anyone on Facebook, if you have any questions, just comment them in. We'll be monitoring, and we can ask the doctor live. All right, thanks so much.
Thanks very much. Thanks for having me. I was here last year during the middle of the COVID-19 infection, and I greatly enjoyed presenting to Gilda's Club. And I'm really happy to be back here to talk about immunotherapy in the management of cancer. Now, immunotherapy has become a relatively important topic in the management of cancer patients, maybe over the last 5 to 6 years. Until then, that's not a big aspect in the management of most cancers. Having said that, immunotherapy had been used for almost about 30 years in a relatively crude form, but it wasn't specific enough for us to incorporate immunotherapy across the board in the management of multiple types of cancers. So in the last 10 years or so, there had been explosive research that was conducted in order to harness the benefits of immunotherapy. And they were able to come up with something that is more universally applicable than the interventions that we had a long time ago. So for that reason, immunotherapy has become almost a standard of care across many common tumor types, including lung cancers, kidney cancers, melanomas, colon cancers, so on and so forth. Now, this is a very appropriate topic for us to talk about because many patients are either going through immunotherapy or alternatively heard about immunotherapy through people who underwent similar treatments. There is certainly some kind of a hype that is building around the efficacy of this intervention. And then there is the reality part of it. There is no question that it induced a lot of benefits in the management of multiple cancers, but the outcomes are not always as if we are achieving a cure for these cancers. So there are multiple things that we will be talking about during the course of our presentation today. We will do a quick introduction and I briefly mention to you what immunotherapy is, but we'll go into a little bit more detail subsequently. Questions whether immunotherapy is right for everyone and whether there is an opportunity for us to receive immunotherapy as part of a clinical trial and what are the potential side effects of immunotherapy. What are the various types of immunotherapy? Although it's a broad term that's commonly used, there are several subtypes of immunotherapy, and we'll go through them in some detail. Is there an impact on the quality of life of our patients when they receive immunotherapy? Because it's, again, something that commonly comes up. Chemotherapy, we all know, is always considered to be an extremely toxic kind of an intervention. And immunotherapy spares patients from the conventional toxicity of chemotherapy, but it is still associated with some additional toxicity, which is not always very apparent in the beginning stages of the treatment. And where are we heading going forwards into the future with immunotherapy? And then we'll address any questions that you have, either the audience that is physically present or people who are on the Zoom conference. So let's talk about what immunotherapy essentially means. It is a type of cancer treatment that is using the body's innate natural defenses in order to identify, attack, and destroy cancer cells. So the immune system is designed to attack a cell that it recognizes to be unhealthy or abnormal and something that doesn't belong to the body. As soon as that recognition happens, it has a way of targeting that cell without affecting the normal cells of the body. Immuno-oncology is a term that we use to describe the field of cancer research that is working to understand the immune system and how it interacts with cancers, and also finding ways of using our own body's immune system to treat or prevent cancer. So immune system consists of two broad subsets of defenses. They're called as adaptive immunity and innate immunity. The innate immunity is a relatively crude evolutionary pathway, which is almost very similar to what a bacteria can do if it is inside a human host or maybe inside an animal. And the adaptive immunity is a little bit more sophisticated. It is able to recognize its targets with greater specificity, so that when the immune system attacks the cells that it doesn't want there to be in the body, it is able to use some more specific targeted kind of mechanisms so that it's not affecting the rest of the body, whereas the innate immune system doesn't have that ability. Now, the immune system obviously is trying to either limit infections, which is the commonest way immunity manifests itself. Whenever a foreign substance, whether it's a bacteria or virus, comes into the body, the adaptive immunity starts off at a later stage, but the innate immunity starts off at the beginning and then deals with the bacteria by producing some chemicals in order to destroy the bacteria, or maybe just engulf the bacteria. And once it is inside the cell, then the cell can destroy the bacteria by multiple mechanisms. That is all the innate immunity, right? So when the bacteria or the virus or any other abnormal cell comes into an environment where the immune cells can start working on it, they carry some tags which are called as antigens. These are proteins that are expressed on the surface of these foreign cells. And the recognition of those cells is extremely important for the immune system to target those antigens and destroy only the cells that are foreign to the body, not things that belong to the body itself. Okay. Now, there are multiple ways in which immunotherapy starts working to fight cancer. Just as a bacteria or a virus is considered to be a foreign entity, a cancer cell is also a foreign entity because it's no longer the same as a normal cell, right? You know, somebody has lung cancer. The cancer cell arises from a mutation or a transformation of a normal lung cell. But by the time the transformation happens, it's almost like it doesn't belong to the lung anymore. So that is the way these immune cells are recognizing them to be foreign cells and then starts to attack them. So marking those cancer cells so that the immune system can see them better is very important. And that marking can either happen naturally because of the presence of these proteins on the cell surface, or artificially, those proteins can be made to appear on the surface of these cells so that the body's immune system then identifies them to be foreign cells and then destroy them. So immunotherapy can also help find cancer cells and deliver treatment directly to the cancer cells, which we talked about briefly in terms of that being a more targeted approach. Most of the immunotherapy drugs are given intravenously, typically through a vein. These can be done either in the office or in a clinic environment or as a day patient in the hospital. We do have a chemotherapy unit in the hospital. That's where typically immunotherapies are all administered. Most of the immune therapies are not done at home. Many chemotherapies can be done, particularly if they are done orally. And sometimes we can also send patients on chemotherapy by maybe putting the drug in a pump and sending the patient home. But immunotherapies, we have not yet been able to do that. Some of these immunotherapies are, toxic enough that recently I had a call from the Mayo Clinic about an immunotherapy, which is called as CAR T-cell therapy, that is used in the management of either certain patients with diffuse large B-cell lymphoma, or alternatively what is called as a lymphoblastic leukemia, which typically happens in the younger patients. And they will keep the patient there for many, many weeks, maybe 6 weeks, 8 weeks. They would not let the patient come home. Even if I say to them that I can take care of the problems locally, they are concerned about the potential immediate side effects. So immunotherapy, although it is generally considered to be benign, can be associated with significant toxicity. So it can be given either by itself, or alternatively it can be done along with chemotherapy or with maybe other immunotherapy drugs too. As we initially mentioned, the immune system is a network of cells, tissues, and organs that are working together to protect the body from bacteria, viruses, parasites, fungi, and abnormal cells like cancer cells. Now, there are two broad types of cells which belong to this adaptive immunity that I talked about. And those two cells are the T cells and the B cells. T cells are much more important in the fight against cancer. It is a type of white blood cell. And these cells protect the body from infection, but also the cancer. And there are two different types of T cells called as CD8 positive T cells and CD4 positive T cells. The CD8 positive T cells are called as cytotoxic T lymphocytes, and the CD4 positive T cells are called as helper T cells. They have different functions. Now, in addition to that, there are other types of cells belonging to the immune system called as natural killer cells, which act in a slightly different way, but essentially they are trying to identify these foreign cells and destroy them, just as the T cells are trying to do. There are certain proteins that are made by the body's immune cells called as antibodies. There are cells in the bone marrow called plasma cells, and there are about 5 types of proteins that are being produced, 5 types of immunoglobulins. Anytime you have an infection, these immunoglobulins are being released by the bone marrow into the bloodstream. And the immunoglobulins are actually expressed on the surface of these cells called as B cells. Now, these B cells then go to the bacteria, to the viruses, to the cancer cells, wherever. And the proteins that are being expressed on the surface, these immunoglobulins, are able to detect the other protein on the bacteria, for example, and attach itself to the bacteria and then destroy the bacteria. Same mechanisms or similar mechanisms operate in the destruction of the cancer cells too. Now, we talked about the tumor antigen, which is a protein expressed on the surface of the foreign cell, cancer cell, bacteria, whatever else. And identification of the protein is extremely important in achieving good efficacy outcomes with immunotherapy. Because cytotoxic chemotherapy, conventional chemotherapy, was considered to be a shotgun approach to the management of cancer. It essentially works at a DNA level and stops the DNA from being produced and thereby causes a cell to die. So any cell in the body that is actively replicating has a lot of DNA multiplication. And when you give chemotherapy to someone, it will not only destroy the cancer cells, which are actively multiplying, but it will also destroy any cells in the body that are actively multiplying too. For example, hair growth is stunted. Because the hair follicles are actively generating hair, right? Or maybe the cells in the bone marrow, they are multiplying every day, producing red cells, white cells, and platelets, so on and so forth. So chemotherapy selectively affects those cells that are multiplying rapidly, which is why bone marrow gets suppressed, increased risk of infections, bleeding, fatigue, so on and so forth. So the expression of the tumor antigen gives the immunotherapy a little bit more specificity, where you are dealing with only those types of cells that are expressing these foreign proteins, right? So that's important. So there is a definition for a term called as biomarker, which is a molecule in the body that we can actually measure. And the expression of these biomarkers in the bloodstream is going to be important to determine what kind of immunotherapy will be suitable for the patients, right? So the higher the level of expression of some of these proteins, the greater the chances are that immunotherapy might be of greater value in that particular patient. If those proteins are zero, for example, there is no real point in administering immunotherapy. We'll start looking at other alternatives. So it's very important that anyone receiving immunotherapy inform their healthcare team about any side effects from the treatment. And although immunotherapy is generally well tolerated, it does cause some side effects. And those side effects, the biggest difference between side effects from immunotherapy versus side effects from chemotherapy, in addition to the generalized shotgun approach that chemotherapy adopts versus a little bit more specific and advanced approach for the immunotherapy, is that the chemotherapy side effects happen fairly acutely. Somebody gets chemotherapy, they start becoming nauseated, they start vomiting, they start having problems with their bone marrow suppression, they lose their hair within, say, a month or so. All these side effects happen very quickly with chemotherapy. Whereas with immunotherapy, people tolerate these treatments very well for many, many months. But when the side effects start happening, they can happen very intensely. The other problem that we also notice with immunotherapy is chemotherapy can cause a lot of side effects, but those side effects are relatively limited. Whereas with immunotherapy, because it's potentiating your own immune system to fight against the cancer cells, can affect any part of the body. Right? So we run into a lot of complications, which we'll talk about a little bit later. So side effects may occur after completing the therapy, but not immediately after, okay, many months after. There are still a lot of unknown things about immunotherapy that people are working on. Now, the biggest things that researchers seem to be struggling to find answers to is as to why immunotherapy treatments work very well in some patients, but not in everybody. Okay, that's obviously a very important question that we don't know the answer to. Now, is it possible for us to combine immunotherapies? Although we do combine immunotherapy with certain chemotherapy drugs and maybe with other immune therapy drugs, is it possible for us to kind of just use it across the board? Because it's only boosting your immune system. So why not use it with radiation? Why not use it with all chemotherapy drugs? Why not use it with every other immunotherapy drug that is available? A lot of research needs to be done, although they look like there are different approaches to the management of cancer. We don't always know where that interaction is going to happen unless you conduct clinical trials. And clinical trials usually take many, many years to come through, so that's a limitation. So when do we actually use immunotherapy in the management of somebody's cancer? You can either do it upfront, you can do it at a second line, at a third line treatment, or maybe you can leave it until the very end of your treatment plan because it's generally well tolerated. So patients, when they're debilitated from the effects of the chemotherapy, so on and so forth, might prefer to use something that's not going to cause them to become very sick, right? So maybe that is the time to use the immunotherapy options. So that decision is going to be determined by a lot of other factors, including the level of expression of certain biomarkers that we talked about. But that is still an ongoing kind of a research. Most immunotherapy that we are using right now, except in maybe 2 or 3 situations, is typically in patients who have metastatic cancer. Stage 4 cancer is where immunotherapy has been developed to begin with. And that's where most of the immunotherapy is being used. But earlier stage cancers like melanomas, for example, or maybe even kidney cancers and certain types of lung cancers, immunotherapy is being used at relatively early stages, not necessarily stage 4 cancers. So long-term side effects, as I said to you, because these drugs have been used only for, say, the last 4 or 5 years, we don't always have the follow-up that is required to find out if these are causing any long-term complications. One of the challenges, obviously, with identifying long-term complications with some of these drugs is if it is being administered in a stage 4 situation, most patients might not have the longevity in order to come up with their side effects. 10 years down the line, what are the side effects from immunotherapy? If you started using it in the adjuvant context of somebody who has breast cancer, for example, they get surgery, they get chemotherapy soon after, and if you're able to incorporate immunotherapy as part of the treatment protocol, those patients might survive for 20 years, and then we will know what these long-term side effects are. So big question that every patient would have is, whether immunotherapy is the right treatment for them. And this is an important question, largely because, as I mentioned, most of the patients are receiving immunotherapy at an advanced stage, usually stage 4, sometimes stage 3. And their cancers either came back after their initial treatment, alternatively, they presented with an advanced stage, and that's when immunotherapy is being used. Right? Some immunotherapy drugs are approved for early stage cancers, as I briefly mentioned a short while ago. And if patients have certain health problems like autoimmune disorders, it is very difficult to administer these drugs because autoimmune disorders by nature are disorders that arise as a result of the patient's immunity already geared up to fight its own internal organs, right? So on top of that, if you potentiate that immune system, then the autoimmune disorders are probably going to get significantly worse. The flip side of it is that when we do chemotherapy for patients who have autoimmune diseases, it's not surprising for us to actually see that their autoimmune problems get better. Like if somebody has lupus or somebody has rheumatoid arthritis or somebody has some other autoimmune problem. Once we give chemotherapy, the immune system goes down with chemotherapy. And T lymphocytes go down, B lymphocytes go down. And the body is actually healing up from the adverse effect that was sustained prior to the chemotherapy. Right? So we suppress the immune system. So the healthcare team can help determine whether immunotherapy is right for us or not. And this is one of my pet peeves, which I'll probably mention briefly here. These days, we are seeing a lot of ads on the television where everybody is saying, we are giving you targeted therapies, immunotherapies, and we are doing precision-based treatments, whatever else. Keep in mind, although those are fancy terms that can be used when you're putting out ads on the television, all these treatments can be administered locally in the community. So I do have a lot of patients who feel that maybe going to the, someplace in downtown Chicago is probably the only way of getting these treatments, but these are not kind of treatments that are available only to 2 places in the world. We are using that across the board. Maybe they have clinical trials, but other than that, these treatments can be administered safely in the community. Generally very expensive, something to keep in mind. And patients who are being treated through a clinical trial may have those costs covered by the insurance, not by the insurance, but by the pharmaceutical company. And there are certain financial issues. I typically do not get involved with that, but there are people who patients can talk to in order to find out what their cost implications are, so on and so forth. Just as some kind of a rough estimate, not out of pocket expenses, but some of these treatments cost easily $100,000 every year to be administered. So they're fairly expensive, and there'll be a substantial copay commitment to certain patients depending on their policies, so on and so forth. So it's important for the healthcare plan to be put in place to find out what the implications are. But by and large, all I can say to you is that although that might be an issue with certain hospitals or certain states or certain individuals, I can't remember the last time where cost was a consideration for us not to be able to administer immunotherapy to our patients. If they need it, they need it. Particularly at Unity Point, we do have a very robust system of trying to support our patients in whichever way possible. So that's not a big issue for 95% of our patients. Many treatment centers have resources to obtain the insurance coverage, as I mentioned to you. Unity Point does a wonderful job of doing that to cover the cost of the treatment. If there is a need to recruit a patient into a clinical trial, I'm sure that many of you heard about clinical trials in the past. Clinical trials are great ways of ensuring progress of medicine. But there are serious limitations to clinical trials. The uptake of clinical trials in the United States is less than 10%. Right? So we don't have a lot of patients who can be part of a clinical trial. One of the reasons is that clinical trials require a huge infrastructure, right? So you need a approval from the clinical trial research organizations that you have the manpower, the staffing, the knowledge, and the ability to deliver those protocols. And because those trials are usually conducted in large tertiary centers, anybody who lives outside those major centers are not going to be able to kind of travel to those places on a regular basis. So accessibility is a problem. Two, many patients would prefer to kind of stick with doing what is already proven to be a good option for their treatment rather than to try something new. Because there is always this kind of apprehension about, yes, you are saying that this could be better than the other one, but do you know that for a fact? No, I don't. In which case, why do I risk my life trying something new? Right? And the third problem that most patients run into is that clinical trials sometimes are also offered at an advanced stage of cancer progression. So by the time cancer progresses, and if you're running out of known options of treatment, then the patients are usually so debilitated that they don't have the ability, the motivation, the strength in order to kind of recruit themselves into a clinical trial. So lots of limitations, but I still think that for the right patient, for the right cancer, clinical trials are probably going to be extremely important. And it is something, we don't have a huge portfolio of clinical trials here, but we are trying to kind of bring them over so that in a community setting, it's important to kind of choose clinical trials that will be of some immediate relevance to our patient population, rather than to try something fancy, which might have no real life implications. So something to keep in mind. So the US FDA and local review boards oversee all the US clinical trials to ensure the safety for the patients, and participating in a clinical trial means that not always. It means that you will receive the best available standard of care. But keep in mind, most clinical trials aspire to achieve that goal, but some of them might not necessarily be able to accomplish that depending on the actual trial protocol. These days, nobody receives a placebo. Most of the times, these are comparison studies. There are multiple levels of clinical trials. They're called as phase 1, phase 2, and phase 3 clinical trials. Phase 1 clinical trial, after animal experimentation, so on and so forth, if you come up with a drug that seems to work, then you try using the drug on human beings. The first level of usage of the drug is to confirm what the level of toxicity would be at a particular dose for the drug. That is called as a phase 1 clinical trial. What they typically do is to start the drug at a low level in a group of patients, and then start the drug at a higher level in another group of patients. So they escalate the dosage to a point where it cannot be tolerated anymore. And then they come down and accept a lower level dosage as being appropriate for human trials, right? The second level, which is a phase 2 clinical trial, is where they use that established drug dosage in patients across the board, because they don't know in whom this works, right? So they will take patients with lung cancer, with kidney cancer, with breast cancer, usually advanced cancer patient, and then start using the drug in 5 different types of cancers. And 1 year down the line, 2 years down the line, you will know which cancers are responding to this drug really well. And the third level is a phase 3 clinical trial, where if they show that this drug works really well for breast cancer patients, they would take a bunch of breast cancer patients and split them into 2 groups. One group receives the drug that is considered to be the standard of care now, and the second group would have the new drug either added on to what is already considered to be gold standard, or just making a direct comparison. Is the gold standard better than the new drug, or the new drug better than the gold standard? Okay, that's the way clinical trials progress. So the point I was trying to make is most of the times, because phase 1 is still early experimental, phase 2 still unknown kind of a exploration, phase 3 becomes very relevant, because I can get somebody and say, you know what, this is what I would have used for your treatment if you were not part of a clinical trial, but there is a great clinical trial that is coming up with a new drug, which I really think will make a difference. So you probably are going to be okay doing the new drug. It's easier to administer and easier to kind of at least propose to the patient. So we talked about the cost of the clinical trials. Most of the times, there is a standard care, like somebody comes in for their infusion, comes in for their clinic visit. All those things are being covered by the insurance people. And the actual cost of the drug is covered by the health pharmaceutical company, which is sponsoring the study. So the patient commitment is likely to be extremely negligible. So we'll talk about the types of immunotherapy. And as I said to you at the beginning, we do have an adaptive immunity and an innate immunity. And as part of the overall immune manipulation of cancer, there are some terms that I would like to introduce. There is something called as a checkpoint inhibitor, which is essentially a protein that is being expressed on the surface of the cancer cells. And I briefly talked to you about cells called as T lymphocytes. And these T lymphocytes usually are able to recognize the cancer cell and then destroy the cancer cell. But if the cancer cell is expressing these checkpoint inhibitors, right? There is a protein called as a checkpoint protein. If the cancer cell is expressing that protein and the T lymphocyte identifies the protein being present on the cancer cell, then the T lymphocyte will not destroy the cancer cell, right? So immunotherapy takes the form of something called as a checkpoint inhibitor. This is probably the most common immunotherapy that we use. So this checkpoint inhibitor goes and blocks off the cancer cell from recognizing, or the immune system from recognizing the cancer cell, which expresses this checkpoint protein, so that the lymphocyte doesn't get weakened and doesn't recognize that there is this checkpoint protein on the surface of the cancer cell and is able to destroy it without any issues at all. Now, there are also things called as monoclonal antibodies, which are used. There are proteins on the surface of certain cancer cells, particularly lymphomas. They express certain proteins called as, for example, a common protein is CD20, a very commonly identified protein in many, many lymphomas. And the presence of that protein actually causes these cells to multiply rapidly and aggressively. And if you're able to use an antibody, almost like a decoy kind of a protein that sits on the surface of the protein on the surface of the cancer cell, then that protein is no longer being stimulated by the other proteins, which means that the cancer cell cannot grow as rapidly and the cancer essentially dies off. Now, there are certain types of treatments called as cell therapies, where you take these T lymphocytes out of the human body, you collect those T lymphocytes, take them away to the lab, and then you essentially make them super T lymphocytes. You put in some drugs which will cause those T lymphocytes to multiply enormously. And you also try to manipulate those T lymphocytes in some ways to recognize the cancer cells, and then re-inject the T lymphocytes back into the patient. And those T lymphocytes will start behaving as if they are supercharged 1,000 times, a million times, right? So that is essentially what cell therapy is. Cytokines are chemicals that are produced by by certain types of immune cells. And the presence of the cytokines causes these cells to be destroyed, the cancer cells to be destroyed. But it also causes an increased proliferation of the lymphocytes that are helping in the management of cancer, right? So in the past, about 20, 30 years ago, there were two cytokines which were very prominently used, called as interferon alpha and also interleukin. Those were the only immunological treatments that were available, and they were being used in the management of kidney cancers and in the management of melanomas. Only two types of cancers and only two drugs that we were using at the time. Now, these cytokines are again very non-specific. One of the biggest challenges using cytokines is when you administer these cytokines at maybe 100,000 times more than their normal concentration, they cause your blood pressure to drop, and they cause your blood vessels to dilate, causing you to essentially go into the ICU. And many of our patients with those drugs were treated in the ICU just because their problems can get aggravated extremely rapidly, right? So those are dangerous treatments. We still use them very sparingly, but not always. There are also vaccines that have been tried in the management of cancers by manipulating the immune system, where you are obviously trying to use an attenuated form of the antigens or the proteins that are expressed on the surface of the cancer cells. And those attenuated proteins are being injected into the body. Right? So the body then recognizes these antigens and starts producing antibodies against these antigens and starts producing a lot of lymphocytes, which not only target these innocuous antigens that are being vaccinated, but also the cancer cells that have the same proteins being expressed on their surface too. Right? So the vaccines are priming the body to react against the cancer cells. Now, there is also something called as oncolytic viral therapy. This is relatively unusual. We use it only in about 1 or 2 types of cancers. A common example is something called as TVEC. They have extremely uncommon and complicated names, and that is used in the management of melanomas. If somebody has a lymph node or maybe a melanoma on the arm, which is a type of skin cancer, we inject the drug directly into the melanoma. So there is an attenuated virus, which then goes into the melanoma cells. And once it goes into the melanoma cells, there is some kind of a destruction that happens within the cancer cells. Oncolysis means destruction of the oncocyte of the cancer cell. So these checkpoint inhibitors are the ones that we talked about a short while ago. The body's immune system has multiple safeguards to prevent it from attacking healthy cells. And these safeguards, these proteins are called as checkpoints. And a common checkpoint is something called as PD-L1. We hear the term very frequently. They slow down and stop the immune system from attacking normal healthy tissue. And some cancers have learned how to activate these checkpoints so that they can avoid being found and being destroyed by the immune system, which is essentially a way of tricking the body into turning its own defenses off. And when we use checkpoint inhibitors, the body is not limited anymore in fighting against the cancer cells, and that has been found to be a very effective approach in the management of multiple cancers. So these are the T cell is on the left side and the tumor cell is on the right side, which looks dark blue. And the proteins that are, let me just figure out where my laser is. Lasers don't work very well on the surface of the screen, I guess. So this PD-1 is a protein. This is a checkpoint protein that is there on the surface of the T cell. And the PD-L1 is on the tumor cell. Now, if there is an antigen, a protein on the tumor cell that the T cell recognizes, then the recognition of the tumor antigen by the T cell receptor, which is the recognizing protein on the T cell, that would normally have triggered some mechanisms which would then destroy the tumor cell. Normally, that's what would happen. Now, if the T cell is expressing this checkpoint, and if the tumor cell is expressing another protein on its surface that can talk to this checkpoint, their interaction tells the T cell not to do anything to the tumor cell. Right? So the normal destruction that would have happened by this mechanism is being inhibited by the interaction of these two proteins here. So what we have started doing is to use certain molecules called as PD-1 blockers or maybe PD-L1 blockers. These are proteins that are synthesized which are designed to interact with either this protein on the T cell itself or that protein on the tumor cell. So by blocking them off, these two things are not talking to each other anymore. And the only interaction that seems to be happening is that the T cell is recognizing the antigen on the tumor cell and nothing to prevent it from doing everything possible to destroy the cell. So most patients who receive immunotherapy are on 2 kinds of checkpoint inhibitors, PD-1, PD-L1. PD-1 is expressed on the T cell, PD-L1 is expressed on the tumor cell. There is also something called a CTLA-4 inhibitor. I won't go into too many details on that, But that CTLA4 is a natural break of the immune system. When I say break, it breaks down the immune system from being hyperaggressive against the body's cells or against cancer cells, against bacteria. So once you take that break off, the immune system is potentiated to act against multiple targets, including cancers. Not all cancers can be treated with these drugs, but we are certainly using it across the board in multiple types of cancers. And there are many, many drugs. Names are relatively complicated, but most people would have heard about drugs called as Keytruda and Opdivo, and other drugs are used relatively less commonly, but they certainly have become a staple in the management of many cancers now. The types of cancers that can be affected by checkpoint inhibitor treatment include melanomas, lung cancers, Hodgkin's lymphomas, Merkel cell cancers, which is a rare kind of a cancer, but kidney cancer, liver cancers, and multiple other types of cancers. Now, I think it is important for me to at least talk to you about the new indication for Keytruda. And I say new indication, at least over the last 1 year or so. Although these checkpoint inhibitors were supposed to be effective in patients in whom the cancer cells are expressing the PD-1 or PD-L1 at very high levels of concentration, the Keytruda received a new approval, which says that if the cancer cell is showing signs of some changes, which tell us that it has a lot of damage happening in the DNA, then just use the Keytruda across the board. It doesn't matter what type of cancer it is, right? It's called as a tumor agnostic management. So it doesn't matter what the cancer is, if there is a change of something called as mismatch repair protein, every time a cell multiplies, there are bound to be some defects in the DNA, right? Now that DNA is actually repaired by proteins called mismatch repair proteins, right? So if those mismatch repair proteins are not functioning well, then the cell is accumulating all these damaged DNA fragments and eventually will turn into cancer, right? So if there is a deficiency of those mismatch repair proteins, Keytruda can be used across the board. Doesn't matter. All those 10 cancers can be treated, maybe 10 more. So we talked about the PD-L1, which sits on the other side on the tumor cell itself, and a couple of cancers that are treated by this particular drug. And as you can imagine, that approval came in only about three months ago, right? So advances are happening almost on a daily basis, new drugs and new indications. And that is the spectrum of cancers that would be benefited by being treated with Keytruda. And the other drug, Opdivo, is also approved in multiple types of cancers. Another drug called as atezolizumab, which is specifically used in bladder cancer, non-small cell lung cancer, small cell lung cancer, and triple negative breast cancer. I think it's at least reasonable for me to talk a little bit about triple receptor negative breast cancer. This is a common cancer. About 250,000 women get diagnosed with breast cancer every year in the United States. A very small proportion of them have what is called as triple negative breast cancer. About 60–70% of women with breast cancer express proteins called estrogen receptors on the surface of the breast cancer. Estrogen receptor essentially is a female hormone receptor. And the presence of estrogen in the body essentially makes these cancer cells susceptible to the effects of the estrogen, stimulating those cancer cells to multiply and become aggressive, right? Now, another 20% of patients with breast cancer express another protein called as HER2. Between the ER positive and the HER2 positive patients, we can almost account for about 80–90% of all breast cancer patients. But a very small proportion of patients have what is called as a triple negative breast cancer, where none of these proteins are being expressed. So you can't actually use these targets to treat those patients. So those cancers are hyperaggressive. They typically happen in young patients, and there is almost always a genetic connection, right? So we are limited in our ability to deal with an aggressive cancer, not expressing anything at all on the surface. And in those patients, some of these immunotherapy drugs have been found to be useful because they're not working based on what the cell is expressing, but working on stimulating the body's innate immune system. So it doesn't matter what the cell expresses, right? So another drug called as durvalumab, used in lung cancer essentially. And another drug which is used in certain types of skin cancers. And we talked about the CTLA-4. These are drugs which take off the brake on the immune system so that the immune system is potentiated to work against cancers, typically in melanomas, colorectal cancers, and kidney cancers. There are quite a lot of side effects to this drug. And sometimes we can combine several types of immunotherapy drugs, and the more immunotherapy drugs are used together, the higher the likelihood of side effects would be. And we also combine them with chemotherapy. And fortunately enough, when we do it with chemotherapy, one of the good things is we have always been limited in our ability to do extensive chemotherapy. There's nothing, when somebody comes in to be treated with chemotherapy, you use a couple of drugs, maybe 3 drugs at the most, but you can't use 5 drugs all at the same time because all those chemotherapy drugs share similar toxicities, and that makes it impossible for you to pile up one drug after the other after the other. Whereas if you administered an immunotherapy drug along with the chemotherapy, they have side effect profiles that are different from each other, which makes it easier for them to receive more drugs without having a lot more side effects. So at least the intensity, the spectrum of the side effects might be bigger, but the intensity of the side effects will be much smaller. That's the advantage. So there are other monoclonal antibodies, which we talked about briefly, which can attach themselves to a particular target on the cancer cell. And that would make the cancer cell susceptible to the effects of maybe chemotherapy, or essentially it loses its ability to kind of regenerate as a result of that inhibition. The administration of monoclonal antibodies is largely confined to lymphomas and also leukemias. We talked about those CD20 molecules in chronic lymphocytic leukemia. And in acute leukemias, there are other types of markers on the cell surface which have been targeted to great effect. Hodgkin's lymphomas, non-Hodgkin's lymphomas, multiple myeloma is another common condition that we treat. So boosting the immune response is accomplished by cell therapy, which is a way of taking the body's own cells and then putting them in a petri dish in the lab, for example, and then boosting the ability of these T lymphocytes to fight off against cancer. And I mentioned to you briefly about the CAR T cell therapy. And this is a hyper expensive kind of a treatment and a very toxic kind of a treatment, but have been found to be of great benefit in patients with acute lymphoblastic leukemia and also something called as a diffuse large B-cell lymphoma. The more complicated the names are, the more expensive the drugs are, right? They make it complicated for a reason. Researchers are also using other therapies against melanomas, cervical cancer, and blood cancers. So we mentioned about interleukin 2 and interferon alpha. These are called as cytokines, essentially chemicals that are being produced by body's immune cells, typically lymphocytes. They don't target cancer cells specifically, but they work by speeding up the growth of these T lymphocytes and also activate other immune cells. So overall, they boost the immune system across the board in a relatively non-specific way. Because it's not a targeted response, we see more side effects, very similar to what we see with cytotoxic chemotherapy. And the examples of interleukin and interferon in the management of advanced melanomas and kidney cancers have been touched before. So there are cancer treatment vaccines which teach T cells to find and attack cancer cells. And there is a drug called as Provenge, which is used in the management of prostate cancer. And I did use this drug in quite a few patients, maybe until 3 or 4 years ago. one of the things that we seem to be running into while using some of these drugs is the cost-benefit analysis. Although cost is not a consideration for most of our patients, at some stage, the efficacy of the drug has to be taken into consideration when you choose your interventions, right? Just because you're not worried about the cost doesn't mean that you're using fairly ineffective medications, because that's not the responsible utilization of your resources. So for that reason, I no longer use Provenge on a regular basis, because the overall survival benefit from that is maybe 3 weeks, 4 weeks. And you're shelling out $120,000 in order to get 3 or 4 weeks of benefit. And patients have to travel to other places and a long waiting time, and this has not really been of any great benefit to the management of our patient. But there are other vaccines that seem to be used on a regular basis. Some of them are still in the experimental stage. And there is a common medication that is used in the management of bladder cancer. BCG is obviously a vaccine against tuberculosis. And the Bacillus calmette-guerin is the name of the particular bacilli or bacteria. Now, an attenuated form of the bacteria can be put into the urinary bladder through a catheter, and that causes the immune system to respond quite intensely, and all these cytokines, all these molecules, proteins are being released into the bladder, and then they attack the cancer that is there on the surface of the bladder. So this had been a time-tested kind of an intervention in the management of bladder cancer, and it reduces the risk of recurrence of early bladder cancers by about 70%. This doesn't apply to bladder cancers that have already spread into the bloodstream or that have gone through the wall of the bladder. Only if it is on the surface, you can put it on. So oncolytic virus therapy uses viruses to fight against cancer cells. The only drug that we know of, which is the T-VEC that I mentioned to you about, is used in the treatment of certain types of melanoma. Other viral treatments are being tested in the management of brain cancers, breast cancers, colon and pancreatic cancers. Possible side effects from immunotherapy. There is a misperception that immunotherapy is a natural kind of a way of dealing with cancer. It is natural in some ways, but it is not so natural, because if your immune system is boosted 100 times, is it a natural response? It's not, right? So because of the potentiation of the immune system, there are likely to be side effects related to this immune activation. Right? Our body's immune system largely doesn't react against its own cells, but when it is 100 times more potent, your normal cells will start noticing the difference, and they will start getting affected. With multiple cycles of chemotherapy, you are bound to have autoimmune side effects, and that can spread across the board, whether it is involvement of the pituitary gland in the brain. I usually, when I see my patients, when they talk to me about side effects of the immune therapy, I try to avoid getting into a big discussion about these side effects, because what will I tell them? They can lose their hair, their brain can become swollen, their pituitary gland can stop working, their tongue can be swollen, their lungs can be inflamed. In the very early days, when I was managing some of our patients with these drugs, I had a call from the hospital about a patient who was kept in the hospital, a 35-year-old woman with lung cancer being treated with this drug. They admitted the patient to the hospital because she was getting increasingly breathless. And they did some scans of the chest which showed some evidence of inflammation. So they presumed that she had pneumonia, and they kept her in the hospital for about a week and gave her intravenous antibiotics, multiple courses of antibiotics. She was not responding. And that is the time that they wisely thought that maybe I need to have some kind of a say in the management of the patient. When I saw the patient at the time, I quickly recognized that this is a side effect from the drug. So just to tell you that it can manifest in multiple ways, very easy to be misled. So these side effects are generally different than the side effects from chemotherapy and radiation. Many cases, they are not severe, but usually not severe until they happen. Once they happen, they can be extremely severe. There is really nothing much that we can do about it, other than putting patients on high doses of steroids and hoping things will get better. But most of the times, about 80–90% of the times, those side effects will not manifest, or even if they manifest at a later stage. But once they happen, they are extremely difficult to control. Common side effects could include flu-like symptoms, tiredness, rashes, redness, pain, muscle pains, joint pains, maybe increased risk of infections. Less common side effects include inflammation of the colon, inflammation of the gastrointestinal tract, problems with thyroid, liver, kidneys, heart, other endocrine glands, other internal organs, lung problems that I just mentioned to you about, and other autoimmune conditions such as pituitary problems or diabetes. The side effects do not occur straight away. They take several months to show up most of the times. And we don't know about the long-term side effects, as I mentioned to you earlier on. It's important because some of these side effects can be very subtle, and it's very important for patients to bring it to our attention at an early stage so that we can manage those problems. Now, the quality of the life of the patients is going to be extremely important, and this is something that I would want Kelly to jump on board.
Yeah, sure, absolutely. So I'm Kelly Kraft, program manager at Gilda's Club Quad Cities. I'm a social worker. And I just want to talk a little bit about quality of life and mental health when it comes to immunotherapy and cancer treatment. So we want to talk about distress, and distress can take a whole lot of, it can look a whole lot of different ways. It can be sadness and anger, which are really common. It can be more severe, like severe depression and panic. And it's mostly just being aware of those different things so that you know when you're seeing more common things and when it gets to the point where you need a little bit of extra help. Stress is a really common thing when it comes to cancer treatment in any way, especially immunotherapy, just because we're making new treatment decisions and we're having to kind of do whole new things with our lives when it comes to cancer treatment. So one thing that I want to talk about is open options. So it's a program that we have here at Cancer Support Community in Gilda's Club Quad Cities specifically, where if you're ever at a crossroads in your cancer treatment, so if you're trying to make a decision, so maybe it's, am I doing immunotherapy or am I doing chemotherapy or some combination thereof. If you're making a treatment decision, you can sit down with one of our licensed mental health professionals and really sit down and talk about your situation, your options, your goals, whether that's treatment goals and life goals together, and come up with a list of questions for your doctor. So when you're facing a treatment decision, you can come sit down with us, get all those what ifs swirling around your head on a piece of paper that you can take to your doctor. And the idea is if you get all the answers to these questions, you have the tools that you need to make your treatment decision. It won't make the decision for you, but it'll help give you all the tools that you need. And another thing that I wanted to touch on, because it came up in the workshop so much, is just that cost of care. That's something that Gilda's Club can help with. We're a place for resources and referrals. So if ever you're wanting immunotherapy or any other sort of treatment, or if there's something else coming up in your lives because of your treatment, like you have to miss work because of treatment or whatever that may be, give us a call. We may have resources available or be able to help you through your insurance. And just a little plug, we do have actually, frankly speaking about cancer, cost of care workshop coming up next month, August 11th at 6 o'clock. So if that's something that is a concern to anybody, feel free to come to that workshop as well. And then stress is obviously a big thing we want to talk about when it comes to cancer and cancer treatment. And it's a lot of just making plans, managing one thing at a time, taking it step by step, and knowing what works with you. So stress management techniques are different for everybody, whether that's journaling, whether that's talking it out, different ways of relaxing, finding what works for you to manage your stress. And be prepared to manage those side effects. Of course, you won't know exactly how a drug is going to affect you until you're on it, but just being ready, talking to your doctor about what to expect. You can also talk to other people who've gone through a similar treatment course as you. And accept help from others. So that's so much easier said than done, I know. but people around you a lot of times really do want to help. And so say yes. And then make sure if there's anything that I can stress on that I can't stress enough is discuss feelings of extreme distress with one of your healthcare professionals. So if that's your doctor, social worker, other professional, if you're having extreme distress, make sure you're talking to somebody about that. And of course, find support. I mean, if you're tapped into Gilda's Club, you've already got one place to look. We have licensed mental health professionals that can help, and a whole community of people impacted by cancer that you can talk to. And then thinking about what type of support is best for you. So is that maybe talking one-on-one to somebody who's gone through a similar treatment? Maybe it's support groups like at a place like Gilda's Club, or it might be more like one-on-one therapy with like a psychologist. Regardless, if that's something that you're interested in, you can always give us a call. You can go online. We can always help tap you into whatever resource is right for you. And also realize that your relationships may be impacted. Everyone has to adjust. When cancer is part of the family, it's not just impacting the person with cancer. But also another thing about Gilda's Club is just we're there for the whole family too. So kids, the adult friends and family. So we also have support groups and programs for everyone. And make sure that you're ready ahead of your treatment to kind of look at what things in your family need to be worked on differently. So kids may need rides to school, or dinners may need to be made, but you may not be able to be the one doing that because of side effects. So maybe lining up some help. And always open communication with family members if you can. And talking about emotional health, that sense of hope can change over time. And just look at different ways to improve your quality of life. And there are so many ways to do this, but improving that level of physical activity, diet, relationships, emotional health, anything you can do to improve your quality of life is going to help with your treatment. If you're feeling better, you can take that treatment better. And find ways to express your emotions, both positive and negative. That could be journaling, that could be talking to somebody. There's so many different ways, but find a way to express your emotions. We don't want anybody holding anything back. And there's always a way to find meaning and quality in each day. And I'll let the doctor take the future of immunotherapy, and then I'll take it back.
So with regards to the future of immunotherapy, it is still a new field, and multiple possibilities are being explored. New immunotherapy drugs are available for use, and many more are being currently tested. And the development of the new immunotherapies is based largely on years and years of work and understanding how the immune system interacts with the cancer cells. And new treatments are going to be developed with more understanding of the research in these areas, which have the potential to change the way in which we treat cancer. Keep in mind that the development of these drugs takes an enormous length of time. By the time somebody understands the pathophysiology or the mechanism of a particular intervention, like how do these immune cells talk to each other, and then understanding how do we prevent them from talking to each other, and how do we come up with a molecule that can do the job, and then is this strategy going to work in animals? Is this strategy going to be too toxic for human beings? And then take it to the level where you are making an appropriate comparison. The drugs that we are using today were probably in development 10 years ago, 15 years ago. Okay, so it takes a long time. They're coming up with some novel ways of trying to expedite the process, but it is not fast enough. So there are multiple resources that people can tap into, including the American Cancer Society, Cancer.net, Cancer Care, National Cancer Institute, and if somebody is interested in clinical trials, they can go to the cancer.gov website, and then there is a patientadvocate.org, which are all extremely useful kind of resources, very informative.
And I can take the lead on these cancer support community resources. So just some things that are kind of lesser known about what we have available here. Our cancer support helpline, if ever we're not available here, is staffed by licensed mental health professionals and resource specialists. So that's just an option. open options I already talked about, and our Frankly Speaking series is what you're at right now. So keep an eye on our calendar because you never know what you're going to see. Month after month, we have different educational workshops. So the Cancer Experience Registry is a really cool thing that I like to tell everybody about. It's a research survey, basically, that gathers information from people with a cancer diagnosis, survivors, and caregivers about what you guys are going through and your experience, to really talk to medical professionals, and it even can talk to policymakers. And we really use that data all over the US to be able to enact change both from the medical side and the policy side. So if you're interested in doing that, it's just a big survey that just gets a lot of information. There's the website for you. It's pretty easy. It walks you right through it once you get in there. Another thing is our grassroots movement. So that big scary word, advocacy. We all think that we want to be able to help maybe with policy. We all have opinions when it comes to policy and laws, when it comes to healthcare. And so if you have those big opinions and you want to help, our grassroots movement is a really great way to start, because there are a lot of big things you can do, we all know, to help with advocacy, but a lot of little things that we can do too. Little baby steps that really can make a big difference. So if you're interested, there's the website there to get involved. Another thing is mylifeline.org is a really great tool. Everything that I'm talking about right now is free. And so this is a great place where if you're getting cancer treatment right now, you can get on this, you can blog kind of about what's going on with your treatment, give that link to all your family and friends, and instead of having to call and text everyone, email everyone all the time. And it's also got a really cool helping calendar. So say you're going to have surgery or start a new treatment, you don't know how it's going to affect you. You can say, I need rides to my treatments, or I'm coming home from surgery and I need meals, for my family. I'm not maybe going to be able to cook. You can enact that helping calendar and say, I need help with this, this, and this, and your friends and family can sign up to help with those things, which is really neat. And it's also a really great place to connect with other people with a similar type of cancer as yours. You can go in and there's different categories, and you can go on discussion boards and ask questions of people, nation worldwide, and, get advice and, thoughts of what's going on. I'm just gonna check in with the Facebook. No questions on Facebook, okay. So thank you to our sponsors for this. And I'm going to end the Facebook Live here in a moment, but thank you everyone for watching on Facebook. And if you have any questions, give us a call, 563-326-7504, or visit us at gildasclubqc.org.